Removal of anal sedin, other marker. The physician removes an anal sedin or other marker. The physician identifies the sedin stitch or other marker at the anal verge. The sedin is divided and removed. The external anal sphincter at the level of the sedin may be divided. Removal of pancreatic calculus. The physician removes a stone from the pancreas. The physician exposes the pancreas via an upper midline incision through skin, fascia, and muscle. The pancreatic duct is opened and calculus removed. The pancreatic duct is connected directly to the small bowel for drainage. The abdominal incision is closed. Removal of implanted intra-arterial infusion pump. The physician performs an upper abdominal incision and exposes the hepatic artery while dissecting free the previously implanted infusion catheter. The physician removes the catheter, and may repair the arteriotomy with suture. The physician closes the abdominal wound, and may leave a drain in place. Removal of Thiersk wire or suture, anal canal. The physician removes a wire or suture that has been placed around the anal canal for rectal prolapse or incontinence. The physician makes incisions in the lateral perianal subcutaneous tissue. The wire or suture that is encircling the anus is identified, divided, and removed. The incisions are closed. Mechanical removal of obstructive material from gastrostomy, duodenostomy, jejunostomy, gastrojejunostomy, or cecostomy, or other colonic, tube, any method, under fluoroscopic guidance including contrast injection, if performed, image documentation and report. Removal of synthetic rod and insertion of flexor tendon graft, hand or finger, includes obtaining graft, each rod. Removal of synthetic rod and insertion of extensor tendon graft, includes obtaining graft, hand or finger, each rod. The physician removes a synthetic rod used to create a natural location for a tube graft and inserts a flexor or extensor tendon graft. The physician incises the overlying skin and dissects to the rod. The rod is removed. A graft is obtained from the palmaris longus tendon or from the foot and inserted in the new position. The proximal and distal ends are sutured into place and the incision is sutured in layers. This code is reported once for each rod that is removed and replaced by a tendon graft. Removal of cerclage suture under anesthesia, other than local. The physician removes a cervical cerclage, a suture that had been placed to hold the cervix closed. A cerclage is most often placed when a cervix dilates too early during pregnancy and risks a miscarriage. The physician severs the sutures and removes them. This code includes anesthesia other than local. Removal of inflatable urethral/bladder neck sphincter, including pump, reservoir, and cuff. In female patients, the physician makes a midline lower abdominal incision to gain access to the space of Retzius. The artificial urinary sphincter is exposed and the plane between the bladder neck and vagina is dissected. The device is removed and the opening is closed using suture for the rectus fascia. The subcutaneous tissues are closed and staples are used for skin closure. In male patients, the urethral bulb is exposed and the bulbospongiosus muscles are left intact over the urethra. The strap of the prosthesis is grasped under the crus and the muscle and the procedure is repeated distally to grasp the second lateral strap. The same maneuvers are repeated on the opposite site. The proximal straps are untied, as are the lateral straps. The incision is closed and a Foley catheter remains for several days. Removal of nephrostomy tube, requiring fluoroscopic guidance, e.g., with concurrent indwelling ureteral stent. The physician removes an indwelling nephrostomy tube under fluoroscopic guidance that was previously placed concurrently with an indwelling ureteral stent. Nephrostomy tube removal may be done to avoid displacement of the stent. Contrast may first be injected through the indwelling catheter tube to verify placement and functioning of the stent. The suture holding the pigtail in place is cut and a guide wire is threaded through the nephrostomy tube under fluoroscopy, making certain that the pigtail or suture do not hook the stent and that the stent remains in proper position. The nephrostomy tube is pulled out over the guide wire, stent position is checked again, and the access site is dressed. Removal of transplanted pancreatic allograft. The physician removes a transplanted pancreas graft. The physician makes an abdominal incision. The pancreatic graft is mobilized. The vascular supply to the pancreatic graft is isolated, ligated and divided. The anastomosis between the duodenum and bladder is taken down and the defect in the bladder is closed with sutures. The incision is closed. Removal of transplanted intestinal allograft, complete. The physician removes a previously transplanted intestinal allograft due to complications such as infection or rejection. The physician makes an abdominal incision. The intestinal allograft is isolated and resected at sites distal and proximal to the anastomosis sites of the previously placed intestinal graft. The distal and proximal ends of the remaining intestine are re-proximate using staples or sutures. The incision is closed.